All right, now I'm going to discuss other diagnostic studies that you may see ordered for your patients where the physician really suspects something's going on, but he really can't pinpoint what the exact problem is until he does this type of testing. Some of these probably are somewhat obsolete. Obviously, we have new diagnostic testing, which gives us really very accurate, precise information, preferably our MRIs and our CAT scans. Some of these tests that I'm just going to go over very quickly have been around from the beginning of time. I remember going down with my patients when I was a student nurse for some of these testings like the KUB and things like that I'm going to talk about very quickly. Many times the physician, instead of putting your patients through some of these tests, will just go ahead and do a CAT scan, whether or not it's with dye or without dye, just to kind of get an idea if really they suspect a tumor or something like that. I think what's important about these diagnostic testings are the fact that you really have to determine whether or not these patients are receiving the dye systemically or just more localized, because if they're getting the dye with these tests that's going through the whole system, then there's always a possibility that these patients could suffer some ill effects from that, because the contrast medium is a nephrotoxic agent. So we have to make sure that our patients have healthy kidneys, and it might be important for the physician to determine maybe how much of that contrast dye they're going to use, so that we can keep our patients safe and avoid any potential complications, especially with a decrease or a lack of kidney function occurring, like acute renal failure because the patient had too much dye during a particular diagnostic test. All right, the first thing, which I think is kind of common to most of us, which I think is a wonderful invention, is your bedside sonography or your bladder scans. This has been so helpful, especially when we have someone who is unable to urinate. We can definitely palpate the abdomen and kind of make the assessment that there is some distension, but we don't really know how much. And it gives us a kind of an idea, because these bladder scans are fairly accurate, to determine how much urine is in the bladder. The good thing is, just need to explain to your patient what you're going to do. Most units each have one in the closet or somewhere. Use a gel to make good contact with the skin. Might want to warn the patient it might be a little bit cold at first when it's put on the skin. And then you see on the machine an icon. You hit either male or female. You use the male icon if your female patient has had a hysterectomy, one that has not had, one that does not have a uterus. So that's just probably the only thing you got to be a little bit aware of, and obviously know a little bit about your patient's history. But for the most part, these really can help us see any post-void residual volumes and really determine if the patient needs an intermittent catheterization. So I like these, and then just make sure after you're done checking that you definitely wipe that gel off, okay, so it doesn't get all over the patient's gown or on his sheets. But very, very helpful, quick diagnostic study to determine if the patient has any significant residual. And some people do a couple. They'll do one and then wait 10 minutes and maybe, go back and do another one just to make sure that the results were reliable, okay? And we're going to look at imaging assessment, some of the retrograde procedures, urodynamic studying, and then, of course, we'll conclude these with a renal biopsy, okay? All right, this particular diagnostic is pretty old. I mean, this has been done, gosh, for the last 30 or 40 years. I remember going down, like I said, with my patients when I was a student nurse to kind of accompany them when they were going to have their KUB. KUB is an acronym for a diagnostic study that's going to look at the kidney, the ureter, and the bladder. The good thing about this is it's a very crude x-ray, okay? There's no specific prep, which is good. It shows gross anatomical features. You might want to do this if you suspect a stone, but obviously the stone probably has to be a good size. Any strictures, maybe in the ureters, calcifications, or any kind of obstruction in those particular areas. And it also helps the physicians see the shape, size, and relationship of the organs to other parts of the urinary tract. Really, there's absolutely no discomfort. It's not a invasive procedure. Patients pretty much lay on their back in a supine position. So it's really an easy test. So no stress or harm is obviously coming to the patient or at risk for any kind of problems. The only thing it is, you just have to remember it's still an x-ray and the person is getting some degree of radiation. But I'm sure, not that I'm a specialist in that, it's probably a very low amount. But obviously, without doing a expensive maybe CAT scan or MRI, they may be able to precisely determine what's going on with your patient. All right, and this is what you would see on a KUB. I'm going to bring this screen down. Right there you see the arrow and what that change in density. You can see it's a little whiter. That indicates that this patient has a renal calculi or kidney stone. So that's what you would be able to see on the KUB. Okay, and remember that stands for kidneys. Your kidneys, your ureters, and your bladder. And obviously we can get and visualize all three of those structures on this x-ray. And it looks like that a person has a kidney stone in their ureter. Okay? All right. This is the one that can be a little bit troublesome. Okay? If your patient has any history of allergies. Okay? This is what we call IVP, or an intravenous pylography, and some of these prefixes really indicate what area that the x-ray is going to view or visualize. Okay, and so this is an invasive procedure. Okay, and they're going to need to sign a permit. Physician should be able to explain this. And I just want you to know as a nurse that many of these diagnostic procedures that are going to be done, it's not up to us to give the patient all the information about the diagnostic. It's up to the physician. We may be able to witness a signature, but that's all we need to do as far as getting our patients prepared, as well as making sure that, blood pressure, and we've probably pretty much reviewed a lot of the lab values, which obviously the physician should be doing too, but and also the proper pre and post care of the patient with these procedures. And you want to kind of think about, okay, what is this going to entail? This is a systemic injection of dye. Okay, and you want to kind of get a good history on whether or not your patients have had any allergies in the past, especially the old cliche was to, shrimp, because shrimp has iodine, and some of these dyes do have iodine. So there was always that correlation that if you were allergic to the dye in the shrimp, then you would be allergic to the dye that was given to you in the diagnostic. Sometimes patients that have maybe asthma or even hay fever are more prone to some of these allergic reactions, and you can kind of classify them as to whether or not they've had a history of minor, moderate, or severe. Many times if there's any indication that there could be an allergic response to this dye, the patients will have an IV started prior to the exam. They'll prep them a day or two with steroids and Benadryl and things like that, and that really works really well because the dye will get out of the system much quicker with an IV, and then it's just a matter of watching the patient, making sure there's no complications during the exam and then when they return to the unit. So those are kind of the new rule of thumb. With this IVP, it's very necessary that the patients have a good bowel prep and that they have good results. And as I said before, these are some of the minor and moderate and severe types of responses or allergic reactions you might see with a patient who might have a probable allergic reaction to the dye. Obviously, we can treat all this, but we sure don't want things like bronchospasm and anaphylactic responses to the dye, so we just want to keep an eye on that. So what's going to happen here is you also want to take a list of medications the patients are on, particularly if they're on metformin. Remember, we talked about this with diabetes. They're at risk for lactic acidosis, so we want to DC that 24 hours before and 48 hours after the procedure. And again, looking at your patient's serum creatinine levels, anything over 1.5 milligrams per deciliter, they may use very little dye, or really determine if this is the best choice of diagnostics for this patient. Because remember, contrast dye is a nephrotoxic agent, and it can induce kidney failure. And it's greatest risk for anyone who is elderly or dehydrated or who already has some kind of renal impairment. So this is why if we suspect an allergy, we'd like to get these patients done early in the morning, and that's why it's kind of a good idea to put a IV in them. Really prevents the patient from becoming dehydrated, okay? So just watch their hydration status, and with proper hydration, it really decreases the risk for kidney damage with the contrast media. Diuretics can also be given after the procedure to enhance dye secretion, really increase urinary output. Patients are in a supine position, and they inject dye, which actually circulates systemically into the blood vessels of the kidney. So our goal is to obviously watch for any type of reaction, encourage fluids, monitor fluids if they have an IV, and then maybe in the morning they'll repeat labs and just make sure that creatinine level is not going up and that there's no evidence of renal impairment, that they're putting out enough urine also. This is what pretty much you would see. Obviously, the patient has to have a good IV, and then once that dye is injected, and that'll all be done in the radiology department, but you can see how it really visualizes. Here's the kidney right here, and you can see this is the renal pelvis that we talked about, one of the regions of the kidney, and you can see the ureter very well in this. Let me just bring this down. Whoops, I wanted to bring this down and show you this this slide. You can see it real good here. You can see it kind of almost looks like a coronary artery. But that's what they're doing here. They're looking at the vasculature, and it's kind of like doing a cath on the kidney. Do you know what I mean? To kind of look at the vasculature within the renal system. Okay, so that's what we call a IVP. And remember, anytime you get a dye, all patients are at risk for nephrotoxicity. And there is a theory that sometimes these physicians have been known to order acetylcysteine or mucomist to be taken orally for the patient prior to this exam, but there's been a lot of disproof that this actually helps to reduce the chances of renal failure. So that's why it's important to make sure we assess lab values, keep the patient hydrated, look for any allergic reactions from their history, and then you know, with doing all that, we can really minimize or kind of eliminate any post-op problems from the dye. Because remember, the dye will rapidly circulate into the kidney blood vessels and is filtered by the glomeruli. So you have dye excreted in the urine, and what this test will also look at is the size, shape, and location of the kidneys, and appearance and patency of the calyces, pelvis, and ureters. And you can see that, we can see that very nicely on the picture. So that's an IVP, intravenous pylography, okay, pylography. All right, so hopefully that'll make sense. All right, the next one is very familiar with, these more sophisticated diagnostics, CT scan, and I guess it's just the question of whether or not we'll give dye or no dye, enhanced or unenhanced. That stands for computed tomography that provides three-dimensional analysis about the kidneys, ureters, bladder, and the surrounding tissues. Maybe there's a suspicion that the patient has a tumor, a cyst, an abscess, or some other type of mass, or some kind of obstruction. Maybe it's a significant renal stone that's present in the ureters, or some problems with the renal blood vessels. Patients may be NPO if they're going to give dye. Okay, so I don't think I have to talk much more about that. Okay, but you know, anytime we are going to give dye, just make sure we have a good knowledge of the patient's history, asthma, hay fever. Have they had any sensitivity or reactions to seafood, eggs, or chocolate? What kind of meds have they been on? Because if they've been on a lot of NSAIDs, it could interfere with normal kidney function. Looking at diabetic meds such as metformin, and really assessing for any dehydration by assessing blood pressure, respiratory rate, looking at mucous membranes, and asking them when was the last time they drank. Okay. And that could also be determined by, you know, how much urine they've been putting out as far as the sense of hydration or dehydration. So that's a CT scan, okay? So the next one we're going to talk about here is a cystography or a cystorethography. And cysto has to do with the bladder, okay? And this is, again, not one of the most common types of testing that they do for a probable renal problem, but we're looking at the bladder, or even the urethra. We explain the procedure to the patient, and what this is going to do is it outlines the bladder wall and can detect abnormalities of the bladder and the urethra. It can also check pressure recordings in the bladder, okay? So what they do with this type of procedure is we really want to explain exactly what we're going to do. So first of all, they're going to insert a Foley catheter, and then they'll inject dye into that catheter, which will go up into the bladder. Now you can see the difference in this test versus the IVP. It's not being injected systemically. It's just injected in a local area, preferably the bladder, okay? So what they'll do is x-rays will be taken, and they'll have to take out the catheter, and then the patient voids what x-rays are taken, and that's why we call it a voiding cystourethrogram, okay? And that will determine urine refluxes into the ureter, and many times we might see this done in cases of trauma or any type of a bladder injury. This cystography will aid in evaluating that vesiculateral reflex, that backflow of urine from the bladder into or both ureters. It also looks at the muscles of the bladder, the ureters, and the pressure of the urine that could cause the urine to retrograde or go backwards, okay? Because we're inserting a Foley, the big concern we have with this procedure is hopefully that was inserted under a strict aseptic sterile technique, and our concern would be a patient developing a urinary tract infection. So once the catheter is in, it's taken out, because the only reason we put the catheter is to inject the dye into the bladder, okay? And again, the patient needs to void, and then x-rays are taken while the patient is voiding. And it won't be nephrotoxic to the patient because it's not in the bloodstream. But we still want to assess for urinary output after the procedure and monitor for any pelvic or urethral trauma, okay? So that's what we call a cystography and a cystorethography, okay? So that has to do with bladder function, okay? And then now we have a renography, okay? And this is what we call a kidney scan in layman's terms, okay? And it provides general information about renal blood flow. They use a radioactive material that is injected when the patient gets down to x-ray, and it provides information about blood flow and glomerular filtration. So they use just a very small amount of radioactive material. It's a radionuclide, and there's no danger to the patient, and it is not associated with nephrotoxicity. So what this will measure is emissions and produces an image on the screen. And that radioactive radionucleotide actually is absorbed in the kidney tissue, and it gives off a low level of radioactive emissions. So there's a camera that records those emissions and produces images. And sometimes what they like to do is possibly change the blood flow, so they'll give captopril, which is Capitan, or a ACE inhibitor, and this may affect blood pressure. So what's important to know is that when the patient returns to their unit, that all this information is given to the nurse, if that nurse would be you, to determine if the patient remains stable with their blood pressure and how the patient did with the procedure. I really find that very helpful in any type of procedure when the patients go off the unit and go to x-ray for some diagnostic. I think it's nice when the nurse down there calls the nurse that has that patient as a patient on their particular unit and just gives a brief little summary of how the patient did and what the vital signs were, or what the condition was when that patient left that particular area, so that the nurse has a sense of how well the patient did, and is there any particular situation or factors that the nurse has to hone in on when the patient returns back to the unit, okay? And remember too that no one is at risk for radiation if you're the nurse that's taking care of the patient and the patient actually urinates in the bed. Just use gloves to care for the linens, and make sure you put those linens in a proper disposable bag. Might want to check with your nurse manager as to what you're supposed to do with them, but I would not throw them down the normal hospital chute, or put them with the other linens that are used to dispose of, because they do have some mild radioactive materials within them. But the big thing is, if they did give the captopril, that the patient still has a good blood pressure with that. Okay, so that is what we call a renography or a kidney scan. Alright, and then now we have what we call an ultrasonography, and what this is just requires the person to have a full bladder, so they need to drink a lot of fluids prior to the test. And what they do is, there's no invasiveness to this procedure. It does not cause discomfort. So it just applies sound waves of areas of different densities and assesses kidney size, cortical thickness, and status of the calyces. Patients placed in a prone position, back upward, and again, it's kind of like the bedside scanner, but we've got the patient laying on his stomach, and gel is used for good conduction. So what they're looking at is identifies obstruction in the urinary tract, tumors, cysts, and other masses without dye. So the gel will be placed over the back and over the flank areas. Okay, and again, after the procedure, make sure that you wipe it off. Okay, and of course, just make sure the patient's okay and very comfortable. But this one isn't bad at all. It's called an ultrasonography. It's just kind of what they do, and sonography is a new type of, I don't know if it's really X-ray, but we use it a lot with like OB patients to kind of look at those first pictures of their baby in utero. So this is the same principle, but now instead of putting it over the uterus, we are looking at sound waves over the kidney area. Okay, and now we do a renal angiography. As I said before, this is a dye used to determine blood vessel size and other abnormalities. This one has pretty much replaced by other diagnostics such as nuclear renal scan, CT, and ultrasonography. So remember, this would be a little bit more dangerous than your ultrasonography that I just got done talking about, because obviously we're looking at the blood vessels in the kidney, and it would have to have a dye, and very much of an invasive procedure which provides dye systemically to the whole body. A lot of times too, when our patients who have coronary disease and they are having a heart cath, many times the cardiologist will move the camera to the abdomen and kind of shoot some dye in the renal arteries to determine if that patient has any kind of stenosis or blockage in the renal arteries that could attribute to the patient's poor kidney function. So that's what a renal angiography is. And you can see right here, this patient does have renal artery stenosis from this. So I just wanted to show you that. It's kind of at the bifurcation, so this might be really hard to put a stent in there, but it probably can be done. Okay? All right. Now we're back. Let me move this up a little bit so you can see the slide better. Now we're again talking about the cystoscopy and a cystorethroscopy. Cysto has to do with the bladder, okay? So what we're doing with this is we are making sure that the patient has provided proper explanation of the procedures. A cystoscopy is done usually if these patients, for instance, might have repeated bladder infections. We want to just kind of look around in that bladder and see what would be causing the person to have reoccurring bladder infections. And many times years ago when I was a student nurse, we used to have cysto rooms on the units themselves, so the patients would not even have to leave the floor when they had a cystoscopy. But it can be performed either under general or local anesthesia. Obviously, with a general anesthesia, then you have also the potential for problems post-op from the anesthesia. So if we can do it locally, that's probably the best way to go. The patient will have a light evening meal the night before, and then will be NPO after midnight, with definitely a bowel prep, okay? They'll determine if the patient would tolerate anesthesia well based on the age and health of the patient, okay? Again, we're looking at the bladder or the urethral area for any kind of trauma, signs of urinary tract obstruction, or just looking if the patient would be having a possibility of a bladder tumor, or even men that might have an enlarged prostate. Sometimes they can also take little snips of tissue and do biopsies with that patient. Now remember, There's no dye involved. All it is just a probe that is kind of put up into the bladder as if you were having a catheterization done. It has a little light on it. It should be done under strict sterile procedure. And that's our big concern, is that the patient does not develop an infection or some kind of bleeding post-procedure, okay? That's what we call a cystoscopy. Okay, so let me bring this down. This is an old slide, but you can kind of get an idea. This is the probe that kind of goes into the bladder, and you can see the end of it. There's a light, and he looks around at the whole area of the bladder to see if there's any tumors, maybe what's the integrity of the walls of that bladder look like, especially for someone that maybe has had a lot of bladder infections this particular year. Anybody that has over 2 infections in a year, we want to kind of do a cystoscopy to determine if there's some kind of abnormality or pathology occurring, okay? So that's a cystoscopy. And obviously, post-op, we want to watch for urinary output, bleeding, and infection. Sometimes they put a catheter in, post-procedure. After a catheter, urine may be pink but not grossly bleeding. But be careful if the patient develops clots that could cause an obstruction. You want to call the doctor if that should happen, because it probably will obstruct the area and the patient will not be able to avoid. Might want to put back in the Foley. Maybe an order for irrigation might be done, and of course to assess for any bleeding we might want to check a CBC and diff in the morning. Okay, so we see the residual effects if the patient had been bleeding from this procedure, how much blood loss has happened. Patients will be in lithotomy position. The cystoscope will obviously go through the urethra up into the bladder. Okay, if the patient had general anesthesia, obviously we'll follow protocol, what needs to be done for that patient post-op. They'll obviously go to the post-anesthesia room for assessments immediately following the procedure, and then you as the nurse will eventually get that patient, okay? But they'll want to make sure that he's stable before he goes back to the floor, okay? So that's a cystoscopy, okay? And again, let me bring the screen up for you to see. Depends on what type of anesthesia was given. Watch for any signs of infection, temperature up, heart rate up. And like I said, it's normal for there to be a little pink-tinged urine, but not grossly bleeding. Okay, that would not be normal. Bright red bleeding would be an indication of an emergency, and you'd want to call the physician very quickly. Make sure the patient's drinking a lot if you don't have an IV, so you can get that urinary output to clear out any kind of pink tinge urine that might be present after a cystoscopy. Okay. Again, monitor for clots, notify the physician for clots or decreased urine output, and may need to irrigate fully with normal saline if ordered, and of course check white blood cells in the morning. Okay. In a day or two, you're going to be able to determine if your patient is suffering from an infection by those signs and symptoms. Temperature going up, patient complains of burning, dysuria, whatever the case may be. Urine may be cloudy and foul smelling. All indications that the patient did develop a urinary tract infection after the cystoscopy was done. Alright, then we have retrograde procedures. Okay, and what this means is retrograde means going against the normal flow of urine. Obviously, it goes downward, but with retrograde, we might see it unflexing upward. They'll instill dye into the lower urinary tract, so the patient's not at risk for any type of dye complications systemically. So there will be no chance of acute renal failure and allergic reaction. All right. Dye is given to obtain a few of the structures of the urinary system, does not get into the bloodstream, decreasing the chance of dye-induced acute renal failure. Procedure identifies obstruction or structural abnormalities. Again, monitor for infection. Follow-up care is the same as a cystoscopy. Okay, so do the same. Watch for infection and bleeding, and you can see this very, very nicely. Okay, everything looks nice and clear. Okay, so and sometimes they do specific areas. Ureters and pelvis, that would be a pyelogram. Bladder is a cystogram. Urethra is a urethrogram. There's no dye in the bloodstream. Sometimes they'll put a cystoscope and then catheters placed in the ureters and renal pelvis, and then they'll inject a dye into all those areas so they can see if there's any signs of obstruction. Then they remove them and x-rays are taken to outline the structures as the dye is excreted. They'll check for obstructions or structural problems in those particular areas. So that's what we mean by retrograde procedures. Okay? All right. We're getting done here. Okay, the next one is the urodynamic studies. Okay, and what we're going to see happen here is they'll do a cystometrography, which is a CMG. They're looking at the health of the bladder wall, primarily the detrusor muscle, how it functions, and how sensitive it is to stretching as the bladder fills. So they're going to really be able to assess bladder function, bladder pressure, and voiding reflexes. So what they'll do is they'll insert a Foley, and with that Foley they'll have a cystometer to the catheter, and they'll instill fluid in the bladder, and the patient notes a feeling of urgency to void, and the point at which he or she notes a strong urge to void. So they're going to, preferably they put in about 500 mLs, but they do it very slowly, so that if the patient at 300 says, oh my gosh, I can feel that, I have to go to the bathroom now, they want to know too at what point as that bladder stretches that you felt that impulse to try to go to the bathroom. Okay, so they're looking at bladder capacity and bladder pressure. Readings are recorded by a graph, and then the patient is asked to void, and then they'll check any residual amount of urine that may be present even after the patient voided. And then after that, the catheter will be removed, so the patient can try to void on itself. They're also looking at urethral pressure and urine flow, and the test of perineal voluntary muscle function. They do also a electromyography, and it really evaluates the strength of the perineal muscles. They'll do urine stream testing and look at pelvic muscle strength. Stopping flow of urine, you start to go, do you have the control to stop that urinary flow? This is probably done for somebody that really has some very serious incontinence problems, okay? We're just looking at capacity, strength of the bladder, and then looking at all those perineal muscles around that, and really assessing urinary stream with that too. So that's what we call by urodynamic studies, okay? And then the last one is a renal biopsy, and maybe they've done all these diagnostic studies and they really cannot find what's going on with these patients. So we want to, now the last resort is to determine the cause of a unexplained kidney problem. Most of them are performed percutaneously using ultrasound or CT guidance, because remember what I said in that first lecture I did for you, the kidneys are very vascular and they don't want to hit a vessel and cause a major bleed in the kidneys, because the patient could die, because remember it provides 20 to 25% of the cardiac output. So this is a very invasive procedure, and it really needs to be explained by the physician in detail to decrease the stress and fear of the patient during the procedure, and also kind of to sit back and wait to see what results come in after the procedure is done. We're going to watch blood pressure, look at their CBC because we really want to treat anemia if the patient does have anemia, and look at those coagulation studies because we don't want the patient bleeding out from this, especially if they're on any type of medication to prolong coagulation. So those are the things that you would do, but I'm sure the physician will do too. They can actually do this in the room, but it should all be done under strict aseptic technique. A lot of times they'll take them to x-ray so they can do a ultrasound or a CT guidance to know exactly where to get that specimen. The thing is, they've got to go pretty deep and advance that needle into the renal cortex. You want to make sure blood pressure is under control, because if the blood pressure is up, the patient could be more at risk for bleeding. Dialysis or drugs may be prescribed before the biopsy. Patients may be given some sedation. Remember, it's done under strict sterile technique. Our concern is infection and, of course, bleeding, okay, with a renal biopsy, all right? It's important, too, that we give our patients very, very precise instructions following the how post-op care will be presented with them and what they're supposed to let you know if there's any signs of problems from the procedure. Major risks are bleeding, monitor for 24 hours, watch that dressing, vital signs, urine output, hemoglobin, hematocrit, and be aware that internal bleeding can occur, okay? So listen to your patient if they have more than usual pain, because these could all be signs and symptoms. Strict bed rest, monitor for hematuria. If no problems, patient may be discharged with specific home instructions. And this is kind of what they're going to do. A small sample tissue is removed with a needle to evaluate a transplanted kidney. Sometimes the patient may have had a transplant and they're looking at the function of that kidney. That might be another reason why we do a renal biopsy. All right, well, that concludes a lot of the diagnostics. I hope that helps a lot. We'll start class with cystitis or urethritis, or if I have time, I may do this lecture tomorrow for you so that we can really start on the care of the patients with urinary problems. I may do this lecture tomorrow, but at least now you have another lecture separate involving diagnostics and then lab testing. All right, have a great night, and let me know if you have any questions.